Good evening, and welcome to tonight's webinar, Taking Care of Your Heart During a Pandemic. I am Dr. Gary Rogal, Chief of Cardiology for St. Barnabas Medical Center and Medical Director for RWJBarnabas Health Cardiac Services. It's my pleasure to moderate this important discussion. As our state reopens due to the success of important measures proven to limit exposure to COVID-19, we need to return to our communities and lifestyles in the safest way possible. The information that you hear tonight is based on what we currently know about COVID-19 and how it is spread. You will want to consult your personal physician about your particular situation. And as we have all learned over the past few months, there are very few absolutes and the situation is evolving. We're continuously learning about COVID-19 and the data is dynamic and moving at a very rapid pace. We are truly living in a period of medical history. Before we pose questions to our panelists, let me lay out a broad perspective on how to think about COVID-19 and your health and well-being. We have learned much about how this virus affects our patients from a study that is ongoing in our system. Early in the year, from the beginning of the pandemic, we designed a study to collect data on all patients presenting with an acute cardiac emergency to our 11 system hospitals. We did this for two reasons. We wanted to know if we had to adjust our approach to our heart attack patients and also wanted to identify major issues that we might face should there be a second wave of infection come the fall. Our data from our large clinical database, which is ongoing, did correlate with that from other major systems in the country and informed us as to the best approach to dealing with COVID-19 patients in an acute cardiac emergency. And in our discussion with our panel, we hope to touch on some of that detail. But it's important to think not just about the acute impact of this virus has on our patients. We should look at how COVID impacts you in two distinct but equally impactful ways. The first way is obvious and involves issues that we identified in our system study that I've already referenced. How does a virus affect heart arteries, heart muscle, and the lungs? What is the biology and pathology of those effects that differentiate them from what might be seen in a non-COVID scenario? But the second and less obvious impact is how COVID-19 affects your environment, which in turn has profound effects on the cardiovascular system. And there's not much discussion about this very issue. Two patient examples illustrate this 50,000-foot view. The first is the observation in our system study that blood clotting in heart arteries occurred in a higher frequency of COVID-19 patients, which is a bit unusual, presenting to the hospital with heart attack. This observation in turn initiated a discussion amongst our system experts about how best to deal with this difficult problem when it arose and allowed us to devise a strategy to contain and treat this clotting phenomenon. But just think for a moment, all of you should think for a moment about how this pandemic has also affected your lifestyle, which in turn has impacted your cardiovascular health. Let me share a second patient scenario with you. I recently saw one of my long-term patients who has a history of coronary artery obstruction, who has struggled for years with a high cholesterol and triglycerides and a lack of regular exercise with excessive weight and substantial stress at work. When I saw him well into the pandemic, I was very surprised. His weight was down, descriptions of a regular exercise program he relayed to me, perfect cholesterol and triglyceride numbers, and him feeling fit and very strong. His workload had significantly declined due to the pandemic, which in turn allowed him to pay attention to taking care of himself. Now that situation can and in many ways has gone the other way with depression and isolation overwhelming our patients, but it does illustrate that we all still have the ability in many cases to move our personal needle in the right direction. This pandemic does not and should not rob us of the ability to use powerful tools at our disposal to maintain our health and our well-being. It is perhaps a silver lining of this pandemic that illustrates the power that effective preventive strategies holds for us all. So I'll close my comments with an important message to all of you who might experience symptoms suggesting an acute cardiac problem. The individual acute care facilities at RWJBarnabas Health and the cardiovascular service line have all worked to provide safe and efficient care at our hospitals and outpatient facilities during the pandemic. Please do not hesitate to seek medical attention as we know that the risk from delaying care far exceeds that from the COVID-19 pandemic. If you have any questions related to concerning symptoms, please consult with your primary physician or cardiologist for guidance. Remember that COVID-19 infection is not just about the heart alone. It is a systemic disease that may affect the cardiovascular system in its entirety, from the brain all the way down to the lower extremities. So with that said, tonight we've compiled a panel of experts in all aspects of heart care to help you and your family live safely within the evolving COVID-19 story. Joining me tonight in our distinguished panel are Dr. Sarah Fan, non-invasive cardiologist with a special interest in advanced cardiac imaging, Dr. Arash Salemi, clinical chairman of Cardiothoracic Surgery, RWJBarnabas Health Northern Region, and a national leader in structural heart procedures involving the mitral and the aortic valves, and Dr. David Dobesh, electrophysiologist and chief of electrophysiology at Jersey City Medical Center, with special training in atrial fibrillation ablation. And all of these folks are my colleagues and my good friends. So we'll start with Sarah, and we have given her a few minutes to just give sort of an overview from a general cardiologist.
Thank you, Gary, for the kind introduction, and thank you for inviting me for this webinar. As a general cardiologist working firsthand with COVID patients during the pandemic, I think it has been a very challenging but rewarding experience at the same time. In the very beginning of the pandemic, I think the challenges for me, along with my other colleague, has been the steep learning curve in terms of learning what are the effects of COVID on the heart and as well as the other organs. Very quickly, we learned it really affects the heart in all facets of the heart. We see many patients, especially hospitalized patients, have heart attacks, whether that being acute plaque ruptures or what we call type 2 MIs, where it's just a demand-supply mismatch from stress overwhelming of the infection. We see heart failures from stress of the heart, where the heart function take a big dip and they drop significantly. And many patients develop arrhythmias, which Dr. Dobesh will touch upon a little bit later. And also myocarditis, where the heart is just inflamed as well. And the biggest thing I think we've seen, which is what you alluded to earlier, was blood clotting. We see lots of blood clottings in the legs, in the lung. People have strokes, and very often we found people to have blood clots in their heart chamber. And that is a very rare condition, which we don't see that often in normal patients. But we've seen a significant amount of patients with blood clots in their heart as a result of COVID. And that has been interesting and learning experience for us to learn how to appropriately treat these patients in the acute setting. So I think that has been very interesting and rewarding for us. Moving after the initial phase of COVID, I think the other challenge that I personally experienced taking care of my patients is how to help my regular cardiac patients with the regular cardiac conditions, how to help them navigate through the pandemics in terms of getting their care, their appropriate care that they needed. I've seen a lot of my patients that have delayed back in May, when we first finally opened our office and opened our hospital back to regular patient care. A lot of my patients have fell off the wagon, so to speak, and they needed I had sent quite a few patients urgently for procedures to the hospital, whether that be a pacemaker, whether that being acute open heart surgeries. There were a lot of emergencies that were out of proportion to what we normally do. And I think in the last few months, that has become the ongoing challenge in terms of educating my patients, recognizing even during the pandemics that they need to take care of their regular heart conditions. And many have come to that realization that's very important to take care of their regular heart during this time as well.
Okay, Sarah, thank you. Go into this a little bit more. You know, the folks who are watching probably don't know what a type 2 MI is. So let's just talk in terms of if you have heart disease, that being ill from COVID and the stress can affect your heart. But even if you don't have heart disease, the illness can in fact affect your heart as well. Could you draw that distinction for everybody?
Oh, sure, absolutely. When we talk, so heart attack can happen in two different ways. You can have patients who have acute, the plaque that are in their heart arteries, they can have acute plaque rupture because of, that's how you get typical heart attacks. In terms of type 2, what we mean is essentially a supply-demand mismatch where patients, because they're so overwhelmingly sick, their blood pressure is low, they are very sick, their heart rate is very fast, so it's a big taxing on their heart. So they also develop cardiac injury as a result of that, of the acute illness.
So even in the case of a person who has a perfectly normal heart, or even a young patient, they can still have damage to their heart as a result of the stress of the infection.
Absolutely, and that's what we see quite a bit of those during COVID. And we really see a full spectrum of cardiac complications in COVID patients.
Okay, so let's talk a little bit about some other things that perhaps we might be able to do or think about fixing in order to prevent the severity of the disease. There's been a lot of talk about vitamin D deficiency, and in patients who have low vitamin D levels, that they may be more susceptible or they may get sicker when they have COVID. Could you address that issue a little bit?
Sure. I think it's an interesting one. I think the discussion came about because there was a recent JAMA article that has published that it was more of a retrospective cohort study. Basically, what they looked at are about 500 patients that went for COVID testing, and they looked back at their previous year's vitamin D level. And what they found was patients in the previous year, if you have low vitamin D level, have about twofold increase in terms of a risk of getting COVID. So the take-home message from that small study is there might be an association. If you have low vitamin D level, you may have higher chance of getting disease. But obviously, this needs to be further evaluated by more randomized control trials. This vitamin D level does not necessarily, at this point, mean that vitamin D can be used as a treatment. And it does not quite, we don't understand whether truly it also pertains to patients' severity of disease if they were to have COVID. I think these are the ongoing research topic that people are looking into. But having said that, vitamin D supplement is, in my opinion, pretty benign. Especially in Northeast, most people are vitamin deficient as they are already, and many are taking it just to improve their vitamin D level for other reasons. So I think it's not unreasonable to take vitamin D supplement, but with a potential reduced risk of getting COVID.
Right. Thank you. So another one, which I got this question all the time about patients who are on blood pressure medications, particularly drugs like losartan, which falls into a class of the angiotensin receptor blocker, ARB. Should patients who are on specific blood pressure medications stop them if they suspect they have COVID, or is there any evidence that being on those medications would either be protective or potentially damaging if they get the infection?
That's a great question. I think this was actually a very interesting discussion in the early phase of COVID when we know very little about the virus. I think the controversy came about because theoretically there is a potential, the medication that you described, ACE inhibitors, such as lisinopril or losartan ARB, they can potentially increase a protein in the body, which the virus binds to in order to get into the cell. Therefore, potentially increase one's risk of getting COVID infection. Because of that, in the very beginning phase, the question is, patients who have been on these medications, should we stop them to prevent them from getting COVID? But as the more data, as we get more data, as we go whether through the pandemic, some Italian data have suggested looking at over 5,000 patients who are admitted to the hospital with COVID. And when they looked at these patients, what they found is patients who have been on ACE inhibitor ARB compared to the matched cohort, there was not really any difference in their mortality rate or morbidity. And so that's very important because ACE inhibitor is a very important part of the medication regimen that we use routinely for our patients. And as we will talk about later, patients who have congestive heart failures, patients who have hypertensions are very often on one of these medications. I think taking them off, looking back at these patients, taking them off can potentially exacerbate their heart failures or potentially exacerbate their blood pressure control, which in turn may make them more susceptible to getting sick with COVID.
So at a bare minimum, don't stop anything unless you speak to your doctor.
I agree. Yes,
right.
Exactly.
Okay. Very good. So this is going to be a theme through the discussion today, and with the other folks as well. But so COVID has pushed a lot of things forward in our lives, I think, just from the perspective of the internet and video conferencing and all the rest. So from the perspective as a physician who refers patients for angioplasties and cardiac catheterizations, what is your feeling about having a patient come in for an angioplasty and go home the same day and not stay overnight, pushing things forward a little bit quicker? Do you think that's safe? Is that something you would advise your patients to try and seek in the situation that they might need an angioplasty or a heart cath?
I am a non-invasive cardiologist, but I have worked very closely with my interventional colleagues. And what we have done indeed is during the time of COVID, we have definitely looked into patients who are considered uncomplicated cases, who are otherwise their procedure went very well. We have indeed actually sent them out safely on a same-day basis. It actually has been done.
So you don't have a problem at all.
Potential. And they've done very, very well.
Right. Okay, good. Talk a little bit about the conditions, the medical conditions that might make a patient more susceptible to developing COVID disease.
I think you mean getting potential complication. I think people who can get disease are the patients, if you don't, you have to practice social distancing, you have to wash your hands, and that's ultimately what one needs to avoid getting sick. But in terms of patients who do get COVID, I think cardiac patients definitely are at much, much higher risk of getting complications. And I definitely have seen it firsthand with many of my patients, especially in the early phase of the pandemic, patients who have coronary disease, patients with congestive heart failures, patients who are obese, people who have simply just hypertension or diabetes. These patients are really at much, much higher risk, not only getting cardiac complication from COVID, but all the other possibilities, such as respiratories, neurologic, you name it. They really do get the worst end of the stick.
And you would agree that if you're under 65, you're not necessarily safe from this disease?
Oh, absolutely not. We actually saw a lot of young patients who were supposed to be no risk factors, who are very healthy, and they get extremely, extremely bad cardiac complications. I've seen a case of young women who's in her 40s with no cardiac or any risk factors, developed blood clots in the heart, had a stroke, had a major heart attack. I mean, it's real.
Okay, so sort of as a corollary to that discussion, so if your conditions, your blood pressure, your diabetes, everything is well controlled, does that make you a low risk patient, or are you still at high risk because you have those conditions?
My personal opinions is I think if you have the risk factor, you're always at much higher risk than somebody who is healthier, and statistically speaking. I mean, there are always exceptions. But however, if your risk factors are well controlled, you always do better than patients whose risk factors are not well controlled. So okay. I do think it's very important that we try to control their risk factors as well as possible, even especially during the pandemic.
Got it. So we have one more minute before we pop into the operating room here. So I've had COVID. What kind of long-term effects should I look for? If you can give me that answer, or long-term issues should I look for that would be of concern? If you can give me that answer in about 30 seconds.
Oh. Well, I think we're all learning, right? We've only seen COVID. We've only lived with COVID for the last 6 months. So it's very difficult to say what kind of long-term complication they may develop. But I do think if the patients had cardiac complications, I would treat them like any of my other cardiac patients, which means if you had a heart attack, I'll treat you like you have a patient with a heart attack. If you had heart failure, I will treat you as a patient with heart failure. You need to be put on medications. We need to monitor your heart functions. We need to monitor your cholesterol, monitor your sugar, see if you have any concerning symptoms in the long run. I basically will take care of the patient who had cardiac complications during COVID, like any of my other cardiac patients. All your risk factors need to be controlled. You need to see the cardiologist on a regular basis.
Got it. All right, Sarah, that was very, very helpful. And now we're going to go into the operating room with my good colleague, Dr. Salemi. So let me ask you a couple of questions, Arash.
Sure.
The pandemic has pushed many things further along, as I said before, like video conferencing and working at home and so forth. And patients are very concerned about prolonged hospital stays. Your structural heart program with these percutaneous valve procedures, TAVR, as it's well known, has a very low length of stay. Do you see this moving, or can we even push it lower with the pandemic for the patients who are concerned about staying in the hospital?
It's a really good question, Gary. It just so happens that these transcatheter procedures, which often represent a minimally invasive alternative to open heart surgery, have actually many attributes that are, I would call them COVID friendly, in that they are not invasive procedures. They do not require a breathing tube. And as you alluded, they do not require long hospital stays. As a result, patients can come into the hospital and potentially leave the next day. In fact, roughly 40% of our patients are in the hospital less than 24 hours. Another 40% go home the second day after the procedure. And so their overall exposure to the hospital is reduced. But it's worth mentioning that, the hospital as it is, particularly here at the medical center, is actually the safest place to be. As a robust cardiac program where we perform several hundred operations a year, and these are tertiary and quaternary care level cases, we knew from the beginning, in partnership with you and our colleagues across the hospital, that we needed to stay a step ahead of the tidal wave as it was coming. And so from the beginning, we created a COVID safe and COVID free pathway for our patients, so that patients would come in and not worry about being exposed. And we did that physically by separating COVID units and flow through of patients from our cardiac patients, and also by not having staff, dedicated to, every unit. We had specialized staff maintained within the cardiovascular space. And so we have stayed ahead. And so whether it's an open heart surgical operation, and again, these are, tertiary and quaternary care procedures. And as Sarah mentioned, they all have the risk factors that we're alluding to. And so they're by definition, high risk for surgery. And so we've taken it very seriously and worked on protocols really over the past 6 or 7 months that have kept our patients safe, and they should continue to feel safe coming to the hospital.
Great. That's terrific. So, if a patient has the recommendation to have a TAVR procedure replacing the aortic valve minimally invasively, and they're reluctant to come to the hospital, so they delay, what would you say the warning symptoms are that they need to pay attention to, which should get them to the hospital quickly should they develop?
Yeah, in general, when we're talking about patients with aortic stenosis, which is the ailment that we treat with these procedures, the standard symptoms are related to chest pain. You might have some lightheadedness, and of course some shortness of breath. And when patients come for evaluation into the hospital, I generally tell them that they fall into one of three buckets. The first bucket is, your lips are blue, you're short of breath, and you need to come into the hospital and get it done right away. Mm-hmm. Fortunately, that bucket's a small one. The intermediate bucket is, you have it, it's limiting your lifestyle, and we need to do something about it. But, you're in control of your own schedule, and you're in the driver's seat as to how you want to proceed. And generally, you and I wouldn't recommend, waiting more than a few weeks, in that cohort of patients. Those are the so-called non-emergent elective cases. And then there are those patients who actually can wait on their valves. They can wait 3 months, 6 months, be reevaluated, maybe even come back a year later. And so, depending on the exact clinical situation, we give the appropriate recommendation. And again, we are mindful of COVID and have pathways for it, but we would not want to pass in a scenario where a patient is severely symptomatic. We would bring that patient in for rapid treatment.
Yeah, so there do remain, unfortunately, patients who are reluctant to come in, and we've all heard these stories about bad outcomes because of that reluctance. So that is not a good thing. So, Arash, in this present environment where we've made provisions for being cautious with our patients, bringing them into the hospital, um, and with the caseload in the population somewhat declining and seemingly controlled now, is it any less safe now to have an open heart surgical procedure now compared to the pre-pandemic time? Or would you say pretty much we're at baseline now, come in and we could operate on you with the same degree of safety we had prior to 2020?
I'm happy to say that we are really, given the regulations and restrictions and protocols and procedures that we have put in place, patients who come to us for treatment are at no increased risk related to the current pandemic. Having said that, if we deviate from what we do and the protocols that we have in place, I think, we can risk unnecessary exposure of patients. And let me just talk about some of the things we're doing. We are limiting the travel and the exposures of the patients to the hospital, really only necessary visits so that there isn't a lot of exposure. We are performing COVID testing within a 72-hour window of the patient's surgery or heart procedure. And we counsel patients to essentially self-quarantine, during that 72-hour phase before their actual intervention. And as I mentioned before, we have dedicated staff. We're eliminating post-procedure and post-operatively unnecessary visits. We do utilize, as you've mentioned, video conferencing in order to get a look at the patients and see how they're feeling as opposed to having them come to visit. We inevitably do like to see our patients in the office after the procedure, but we've limited the number of office visits. And so I'm happy to say that with the care that we've been able to provide here, that the risk is not increased in its current form.
So here's a tough one, and I got this from one of my patients, and I wasn't 100% sure to answer. It involves complications after surgery. Now, we know that you guys never have any complications
That's right.
in our program. That never happens. And that's all a great thing. But in the rare instance where a complication should occur, patients may have to come back to the hospital more frequently. How do we address that? Do I say to my patient, don't worry about that? Yes, complications indeed do happen, but we are perfectly well equipped to take care of those frequent visits or whatever you might need, or even rehospitalization should the need occur. How do we speak to that issue for patients?
Well, I think it's a good question, Gary. I think it's important to highlight a few things. One is that the units that we utilize for our patients have not been exposed to COVID. They have no COVID exposure currently. The admissions come directly through our office space, and in the event that there is a complication, while we try to limit visits to the hospital, there is not necessarily an increased risk related to that. Sarah mentioned social distancing, the wearing of masks. In the hospital, we are required as staff to wear masks. We have temperature checks upon entry of anyone into the building. So we have a lot of measures in place that can really help to ensure that the patient experience is a safe one. In the event that there is a complication, then again, also it's the risk benefit. It always comes down to that. So if there's a complication related to the procedure, the risk of managing it and the trip to the hospital is far less than the benefits potentially that can be achieved. And so, and hospital admissions or readmissions would be a very low risk scenario. As I said, our hospital units are COVID free, I'm happy to say.
Well, that's exactly what I told my patient. So here's a tough one. We have actually, this would have to be a quick answer, but is there ever a scenario where you might consider recommending a very sick patient have angioplasty as opposed to bypass surgery to open up their arteries at this point in time?
Yeah,
because of the risk issue.
as you and I know, we often have conversations with patients and amongst ourselves as to what the best path is. And that decision is often based on a risk stratification again of what the benefit is of one procedure versus another. And so we approach, in a very sort of multidisciplinary way the care of our patients. You and I are always talking, and our colleagues are always discussing the best therapy for our patients. And I think if there's someone who's COVID positive who may benefit from one procedure over another, we would certainly entertain that together. But I don't think that there's added risk to one procedure over the other of contracting COVID.
So it speaks to our collaboration. Thanks very much, Arash. That was a great discussion. And now we'll turn to Dr. Dobesh, our eminent electrophysiologist. David, you're on.
Thanks a lot, Gary. It's really been a pleasure listening to Sarah and Arash tell us their experiences. I think it's been quite an experience for everybody who's been involved over the past few months as we went through sort of the peak of the COVID surge in our area, and then now have gotten back closer to a time of normalcy. The interesting about electrophysiology, I mean, there are many interesting things about it, is it covers a wide spectrum of patients. I see 25-year-old healthy patients. I see 95-year-old patients, and they have a number of illnesses or sometimes have no illnesses at all. And during the first few months of the pandemic, there was a big push to be doing more telemedicine. We weren't able to be in the office interacting personally with patients as much. So the RWJBarnabas Health System really did push us to implore telemedicine to see as many of our patients remotely as we could. And I have two big groups of patients where the question almost always was, how does this COVID affect me? Am I at greater risk of something? I see a lot of patients with atrial fibrillation and arrhythmia management. And, they've heard that cardiovascular disease may put them at greater risk of having COVID, or if they get COVID, may put them at greater risk of having a severe course of pneumonia or winding up in the ICU or on a ventilator. And I will say that just generally speaking, just having a history of atrial fibrillation has not played out as a risk for developing COVID or complications of COVID. So I think just because you've been told that you have AFib or you take arrhythmia medicines, I don't want people to be too alarmed. That being said, this whole coronavirus is novel because it behaves differently in many ways than many of the other coronaviruses we've treated over the years. These subset of patients, when they are hospitalized, we do see greater amounts of arrhythmia. I was consulted on many patients with active COVID because they develop atrial fibrillation, tachycardia, ventricular arrhythmias, and it may be due just to the infection itself or the many things Dr. Fan alluded to that go along with it. These people have higher instances of blood clots in the lungs and the heart. They have fevers. Their oxygen levels are lower a lot of the times because of severe pneumonia. And there are just myocarditis or direct implications to the heart, where we saw a lot more patients in the hospital critically ill developing arrhythmia issues. So it's a little of both things. If you're at home and you have atrial fibrillation, I don't think it puts you at an increased risk for something. But if you end up in the hospital with a severe case of COVID pneumonia, it's definitely more likely that you could develop arrhythmias that we need to help manage as part of your multidisciplinary team taking care of you. The second big group of patients besides our arrhythmia patients are our device patients. We see thousands of patients with pacemakers, defibrillators, and a lot of them, they think, hey, I have a cardiac issue. Does that fall into the high risk cardiac pool? And I'm happy to say that if you have just a pacemaker, that is taking care of your heart rhythm, keeping you regular, that alone does not predispose you to having COVID or a severe case of COVID pneumonia. But there are some patients, as Dr. Fan alluded to, with congestive heart failure. We know that things like congestive heart failure, pulmonary disease, and glucose intolerance or diabetes do put you at greater risk of having a severe illness. Many of our patients who have defibrillators do also have some of these other illnesses. but just the presence of the device itself. If you have a cardiac implantable device like a pacemaker defibrillator, that alone shouldn't make you more apprehensive or scared that something's going to happen. You should just continue to practice the current guidelines, which are wearing a mask, social distancing, and New Jersey has done a phenomenal job of that. Back a few months ago, almost every consult I saw was for COVID or COVID-related pneumonia or complications. Now, when I walk around the hospital, I know that there's only 1 or 2 patients that are even under investigation for potentially having COVID, and they're in a dedicated unit with dedicated nurses. I really think we've come a long way.
Mm-hmm. For sure. All right. So you mentioned devices and the devices that you guys put in, like defibrillators and pacemakers. Does the presence of the infection affect how those things function? So if somebody has COVID and they're home and they have a pacer or a defibrillator, do they need to be worried that their device will not function as it should and be speaking with you or not?
No, that's a really good question, and it's a concern that was voiced to me by other patients on a lot of these telehealth calls, because some of them, fortunately, a lot of people do have a quote milder version of COVID where they didn't require hospitalization. They were able to self-isolate and be at home and treat their symptoms. If you have a pacemaker or a defibrillator, COVID's not going to hurt it. Your device is going to be working regardless of having COVID or not. Fortunately, now in today's device era, most patients have a remote monitoring system at home, which connects their personal device to a Bluetooth-enabled base that transmits regular updates to our office, which are being routinely screened. Now, as we said, there are more arrhythmias in the hospital when people have a bad COVID pneumonia. We're not really sure on how that affects people at home. Maybe people who have a less severe course of pneumonia will notice, hey, my heart rate is elevated more than it usually is. Or maybe they're having more palpitations than normal. Just because you don't have to be in the hospital if you acquire COVID doesn't mean you shouldn't be paying attention to your body. Mm-hmm. And if something's alarming you, if you feel your heart rate is elevated, if you feel you're having palpitations because of the illness, don't hesitate to reach out to your physician that you normally interface with to see if further investigation is warranted.
So, okay, that's great. So we talked a little bit about procedures and people worrying about staying in the hospital from the perspective of angioplasty and bypass surgery. Could you talk a little bit about the watchman procedure and MitraClip, which you're involved in? Maybe very briefly describe what those are. And are you moving to doing those procedures on a same-day basis, as we talked earlier?
That's a really interesting way of looking at it. I am an arrhythmia doctor, so I specialize in ablation procedures where we are going through the vessels of the thigh up into the heart to manage arrhythmias in the top left chamber of the heart, which is the left atrium. So, for the past 2 decades, I've been spending a lot of time with ablation catheters, making measurements of electrical signals in the left atrium. Over the past 5 to 10 years, as this structural heart world has unfolded, 2 big procedures that are surrounding the left atrium have been falling into my territory. One of them is left atrial appendage closure devices. The current FDA approved one we've been using for the past few years being called the Watchman. And it's designed to reduce risk of stroke or clot formation in the top left chamber of the heart through a procedure. Most people historically took a blood thinner to reduce that risk, common ones being warfarin, Xarelto, Eliquis, Pradaxa. But now there is sort of a plug which we can go into the heart and seal the area where these blood clots come from. We're one of the biggest centers on the East Coast, if not top 25 in the country for that procedure. And we have over 300 of these done just in the past 2.5 years. Originally, we were concerned that this was going to be a high resource utilization procedure, but as we've learned, the nice thing about this procedure is it's just done through a single IV in the vein in the thigh. We use closure devices, which are basically absorbable stitches to seal the area up, and almost uniformly people go home the next day. Have we moved towards same-day discharges on them? In isolated cases, we have. People who usually get the Watchman device are people who are not great subjects for long-term blood thinners. So they may be elderly, they may have a gait disorder, they may have other things like congestive heart failure, diabetes. So, we try to make sure that people are healthy enough to go home on their own and have sort of a good support structure with family to help them. So have we sent some people home after this procedure? We have, but we still have most of them stay overnight for monitoring. But I can easily envision where we move towards same-day discharge for more and more of these patients. The other procedure you alluded to is the MitraClip. Much like the surgeons are repairing and the interventional cardiologists are repairing and replacing aortic valves through sort of minimally invasive arterial punctures, we're able to repair many mitral valves by going through the veins in the thigh. The mitral valve, as everyone knows, sits right below the left atrium, between the left atrium and the left ventricle. So, like I said, I spend a lot of time in the left atrium. You just have to take a look down below you, and there's the mitral valve. These procedures, similar to watchmen, are done through a single IV down in the vein in the thigh. And afterwards, we seal that up with an absorbable stitch. And almost everybody goes home the next day after a mitral valve repair. I think our experience has mirrored the TAVR experience where, if you have a lot of other medical conditions or congestive heart failure, maybe you need another day to get your legs under you and be ready to go home. But I would say the overwhelming majority of those patients are also just going home the next day. It really has been great to see this field of structural heart grow, and we're kind of, the coincidence of it being available during this time has really saved a lot of patients a lot of concern and prolonged hospitalizations that they otherwise would have had to endure.
Okay, so you're an atrial fibrillation expert. You've got 20 seconds to tell us if your approach to that dysrhythmia has changed during the COVID pandemic. And actually, it's 15 seconds.
I'm going to use 5 seconds to tell you that I really appreciate that question, Gary. That was a good question. But I would say that we are spending more, I'm doing many more telehealth visits. I have a lower threshold for when a patient calls the office and I get a message, so-and-so called, they have palpitations. This patient had a question about their medicines. I'm much more likely to say, set them up for a telephone visit with me tomorrow or a telehealth video visit with me tomorrow, rather than waiting a week for them to be seen in the office. I think that the push for telehealth has really changed the way I practice, and it doesn't replace an in-person exam and conversation and discussion. But you know what? To make one visit in between so you don't feel like you're losing touch with your patient or physician, that really has helped me a lot.
Yeah, so that's just another way that things have been pushed forward, certainly in medicine, as many other things in the rest of the world. So, David, thank you very much for those very insightful comments. We have about 2.5 minutes for just general comments and discussion about important points that people might want to make. From my perspective, I think clearly the most important thing I could tell folks who are out there, and we've heard it from several of our panelists, is that if you do have a symptom, do not hesitate to come to the hospital if there's a symptom of concern. In some countries and some actual studies that were done, like in Northern Italy, they demonstrated that the chances of getting ill and getting sick and having a very bad outcome clearly was related to the fact that patients not only didn't come, but also in those patients who presented late to the hospital. It's really not a good thing. And most hospitals are prepared to deal with patients in COVID-free environments. So I'll open it up to any of my other panelists for any other closing comments that you might have, words of wisdom.
Well, I think it's, Sarah, go ahead.
Oh, go ahead.
Please.
Go ahead. I was going to say that for my patients, as a general cardiologist, my biggest advice to my patient that they come in now is to stay active and continue to exercise while practicing social distancing and stay safe. But it's very important for them to stay active, stay healthy. Some of the patients, like Gary have mentioned, they have gone to the one extreme where they become very active because their workload has decreased, they become healthier during COVID. And I also have on the other spectrum where patients really become couch potatoes, they're not doing anything. And because they can't go to the gym, they can't go to the Y, they can't swim, they can't do their indoor sports, and they really have put on a lot of weight. They're really worried about going outside. So they've really become deconditioned. So my advice to my patients are really try to stay healthy, stay active, you know, due to general precautions, but definitely stay active. And also see your doctors on a regular basis to make sure your cardiac risk factors are well controlled to prevent any potential exacerbations.
Okay, so we've run over a little bit. And Arash, you've got a couple seconds to share your final thoughts.
Well, the final thought really being, you know, that it is important to reassure our audience that the hospital ultimately is a safer place for you if you're having a cardiovascular event. And actually the risk of transmission is far less than it is in the community. And so if you're feeling, you know, any symptoms that draws you to the hospital, you know, I'm happy to say that you don't have to hesitate. It's a safe environment and we'll take good care of you.
All right, great. Well, I want to thank all of you. Thanks to all of my panelists. Thanks to all of you who have watched this. And have a good night, everybody. Thank you.
Thanks for having us, Gary. Have a good evening.